So we have a very great panel today. We have great presenters. The first we are going to call Dr. Thomas Santo. Tom is a postdoctoral researcher at NDARC, University of South Wales, Sydney, and he's specializing in data linkage and observational research on opioid dependence. His research is also focusing on opioid dependence treatment, harm reduction services during and post-release in prisons. Thank you very much, Tom. The floor is open for you to make your presentation.
Thank you very much. And thanks everyone for being here today. My name is Tom Santo, and I'm a postdoc research fellow from NDARC in UNSW Sydney. And today I'll be presenting on the coverage of services related to infectious disease and injecting drug use among in prisons globally. I'd first like to acknowledge the Gadigal people of the Eora Nation, who are the traditional custodians of the land on which we did most of this research. I'd also like to note that the over-incarceration of First Nations people globally has had a major impact on health and social outcomes, and is something that is quite important, I think, to acknowledge throughout our work in prison services. I'd also like to acknowledge the team that worked across this. You would have seen Louisa Degenhardt's presentation this morning, who has led these reviews throughout, and also reviews related to infectious disease and among people who have injected drugs in the community, and the coverage of related services. The large amount of NGOs and global experts who contributed to the data that we were able to collect for each service was critical, and would just again like to thank everyone who was involved. So as many of you know, infectious disease and injecting drug use are risk factors for incarceration, not only due to the criminalization of drug use itself, but also the prison environment increasing the risk of infectious disease and injecting risk behaviors. Previously, Louisa's team at NDARC has done a series of global reviews on the prevalence of injecting drug use globally, and also the coverage of related services, such as NSPs and OAT in the community. And the main aim of this series, I guess, was to estimate injecting drug use in prison, but also look at infectious disease across all people who are incarcerated, not only those who inject drugs. This just shows here a review led by Sam College, who looked at the coverage of OAT with respect to the amount of people who inject drugs in each country, and then the coverage of OAT and NSPs in relation to those prevalence numbers. So that was the aim of the work, was to do that and among prison environments. We searched over 72,000 studies across gray literature and published sources, and we also contacted different NGOs as well as global experts to confirm availability of data, as well as coverage of services in terms of number of clients who received a service, number of needles distributed, or number of tests that were conducted. We searched in multiple languages, and we also searched each correctional health service website, as well as each Ministry of Health website, with terms related to the outcomes that we're looking at, as well as the prison environment for the Ministry of Health sites. So what we found, as Louisa I mentioned earlier this morning, over 1.3 million people who've estimated to have injected drugs once during their life, and we have only 10 countries providing NSPs in prisons. And you'll see here, and this is throughout the maps, we label the blue here as one or more facilities, so that could be a single facility or up to all facilities. And then all facilities is in the green, where we have just, I believe, Spain, with all facilities providing NSPs in prison. And that's 5% of countries globally, and that compared to 94 countries in the community that provide NSPs. For methadone and buprenorphine, not counting antagonist treatments, just OAT, we have 59 countries that provided OAT in one or more facility, and then 19 countries providing OAT in all facilities. Programmatic data was more available for OAT compared to some other outcomes, with 21 countries providing at least one estimate on the number of clients on OAT. And unsurprisingly, when we compare that to the estimated number of people who inject drugs within, from Louise's results, low coverage. However, we weren't able to go as in-depth as our previous reviews in the community that had further information on the number of needles distributed, number of clients on OAT, specifically for each country, which we'll go now to HIV treatment. So for testing, I don't have these slides up, just in interest of time, but testing, we found documentation of 79 countries providing routine HIV testing within prisons, and then 78 providing ART. We'll see, I guess, throughout the slides, that Western Europe having what we found as the highest documentation of coverage, and then we see more here in Latin America and Africa compared to some of the other interventions that we'll go through, and as well as NSP and OAT. For hepatitis C testing, we have 53 countries, or 26% of the 207 that we reviewed, providing any form of hep C testing, and then 47 or 23% providing direct-acting antivirals. We did not include interferon within our coverage of hepatitis C treatment. For tuberculosis treatment, well, for routine screening first, we have found 94 countries, so this is the most available intervention for routine screening. And then for tuberculosis treatment, 79 countries, or 38% of those globally, with TB treatment available within prison. So when we look at this across all the interventions, we can see, at least the treatment interventions, we can see how low the coverage is in terms of population. So when we look at the population of each country, and in terms of their prison population, and then look at the amount of people that live in a country, for example, with one or more one or more OAT program in prisons, that's the blue bar there, and then the prison population of those who are in a country with, say, one or more, or all facilities providing ART, that's that green bar that we see there. And then red is documented unavailability. So we have documentation there to say there is no service that exists. And then the gray is the unknown. So across the top interventions, we can see a lot of undocumented or unknowns availability for services. For the overlap of treatments, when we look at the most common is obviously none of the interventions that we had listed in terms of what combinations of each service was provided within the prison. So that covers, I think, 3 countries that have all of the interventions when we look at NSPs, OAT, and all the treatment interventions we discussed. And that is approximately 600 people of the 11.2 million people incarcerated that have all of the services within within all prisons. So overall, unsurprisingly, the availability and coverage of services was scarce, and that's in comparison to the drastic disproportionate rates of injecting drug use and infectious disease among people who experience incarceration. Across all services, testing and treatment, there was low availability, but particularly when we look at OAT and NSPs. And we can see the comparison there of what's available in the community compared to what is available in prisons. And so if we look at OAT with the number that have, I believe it's 51 with OAT available in prison in one or more facility, and 96 globally, or 86 globally. We have 31 countries that are not providing OAT in prisons, but do so in the community. So we have people going into prison that are taken off OAT, and we know that that's the case globally. And a lot of cases, even where there is one or more prison that provides the service, but this is at the minimum the number of people that are not receiving services that they need. When we're talking the services that are available, even those green and blue bars, there's not a lot of client level or coverage data in terms of the number of tests and treatment, number of people on treatment that would allow us to look at whether or not people are meeting, or countries are meeting targets in relation to Hep C elimination and the other global targets that are set forth by the UN and WHO. Again, this just reiterates the lack of data availability and looking at the coverage review where we had that first graph by Sam College-Frisbee's work on NSPs and OATs in the community. There was far more data on the number of people getting services, and we can look at that in comparison to our rates of injecting prevalence and then estimate what the coverage is like and how many people are actually receiving the service in comparison to those in need. And again, facility level data versus individual level data. The facility level data doesn't tell as much in terms of what the actual coverage is. You can have it available in a facility. What does that mean in terms of access for numbers of people that are actually receiving a service, whether that be in all facilities or in one or more? If we don't have that documentation in terms of client level or test level or needle level data, it's going to be impossible to actually look at how many people are receiving in comparison to the need. Overall, looking at the international standards, the Nelson Mandela rules that were convened here in Cape Town in 2015 and agreed to in terms of everyone having the access to health care that they have in the community and having that same right to access health care in prisons. And we're clearly seeing that there's not that availability. And as Rick mentioned earlier in his presentation today, the implementation of these services doesn't end with policy. It ends with people actually reaching and receiving the services that they need. And so there's a lot of work to be done, and I'll leave it at that. But thank you, everyone. I'll note just before that if there's any additional data that people would like to provide or feel like we got something wrong, very happy to take feedback, and also would love to collaborate. So thanks so much.